Again, we'll just wait a few more minutes just to give people time to come in so they don't miss anything. I should let everyone know that this webinar will be recorded. There were a lot of people who showed great interest in attending, but they can't actually watch live, but they have registered and we are recording, so we'll be able to share this, the link to the recording so that everyone can catch up. And if any of you want to look at the presentation again, you'll be able to do that as well. So my screen says Dying with Dignity. Some of you may know me. I'm Shane Higson. I've been campaigning for voluntary assisted dying laws for 10 years, and I was Vice President during most of the campaign, but now I'm the part-time CEO. But I'll leave just Dying with Dignity there, but you know that I am Shane. Then, okay, what time have we got? 3 minutes. What do you think, guys? Let's just make a start. Yeah, okay. So welcome everyone. I'd like to begin by acknowledging the traditional custodians of the land where I am this evening. It's the Gadigal people of the Eora Nation, and I want to pay my respects to their elders past, present and emerging. As I said, we've had an amazing response to this webinar with just under 1,100, that would be scary, wouldn't it? 1,100 registrations in just over a week. So I'll just move to the next slide. No, why is it not doing it? Oh. There we go. Although I imagine that most of the people watching this webinar are accustomed to talking about end-of-life care and death, it's still possible that some of you may find parts of the presentation upsetting. So if anything we talk about this evening raises distressing issues for you and you need to talk to someone, please call a support line, either Lifeline on 13 11 14 or Beyond Blue on 1300 224 636 or any other counselling service you may have access to. So by the end of this year, people living in New South Wales will be able to access the new voluntary assisted dying law. However, most of us, advanced care planning will still be the most effective way to ensure that our loved ones and our medical teams know what matters most to us and respect our treatment preferences. So advanced care planning is about your future health care. It gives you the opportunity to plan for what you would want or not want if you become unable to make or communicate your own preferences. To discuss this topic, I've just got to remember, in more detail, we're very fortunate to have two extremely experienced guest speakers, Professor Colleen Cartwright and Nurse Anne Meller. Professor Colleen Cartwright is Emeritus Professor and Chair of the Human Research Ethics Committee of Southern Cross University. She has extensive teaching and research experience in ageing, ethics and medical decisions at the end of life at national and international levels, with publications in major journals and several book chapters. She regularly runs information and training sessions on end-of-life care, including advanced care planning, informed consent, and capacity and use of telehealth, with particular focus on the special needs of people with dementia and their carers. Her research has also covered issues related to voluntary assisted dying, both in Australia and internationally. Anne Meller is a clinical nurse consultant employed by Prince of Wales Hospital in Sydney. Her role is to assist adults and those close to them with advanced care planning. She has over 30 years of experience in aged health care from a variety of positions and settings. She holds a Bachelor of Health Science in Nursing and has completed postgraduate studies in gerontology, public health and health administration. She has published several papers in peer-reviewed journals. She was a principal investigator in a recent New South Wales health study to train and support clinicians via an outpatient setting to discuss advanced care planning options with their patients. I will now hand over to Colleen. I shall stop sharing first. Whoops, well, I knew that would happen. Right, and Colleen, if I could ask you to share your screen. And we'll
Certainly, thank you. So it looks like it's come up well, Shane.
That's great.
We did our little trial run before, everyone, so I hope this works well for you too. So thank you very much for the invitation to be here today. And what I'm going to talk to you about is advanced care planning and other end-of-life issues. Why is that not going down? Ah, there we go. Is there any way we can stop the notifications going across our screen? No? Anyway, on we go.
I don't think the audience can see them. They might be going across your screen.
Right.
I can't see anything going across your screen.
Right. Okay. I just keep every few seconds getting the telling me how many people have entered the room, and I really don't need to know that, do I? Okay. So better living conditions and healthcare have led to increased longevity. There are almost 3,700 people in Australia aged 100 plus, and the fastest growing age group in Australia is the 85 plus group. I was interested when I was re-looking at the data just a couple of days ago to note that pre-COVID, we had 4,200 people aged 100 plus. So that figure should have increased, and instead, of course, it hasn't. Because of better care and improved technology, many people with disability are also living much longer than previously. And many older people fear what their life and care will be like at the end stage of their life. And those who are caring for someone with a disability fear what will happen to that person when they can no longer care for them. Sorry, I'm just not sure why this isn't going down, Shane.
Using your down arrow on that, yep.
Yes, I have been.
Yep.
Okay, so sorry, the screen isn't letting me see headings and things, but let's see how we go. So the title up there, which is covered up a bit, but is community concerns in terminal illness. And what I want to show you is the rank order of concerns. We asked big population-based groups of people, if you were terminally ill, what do you think would cause you the most distress? In every study we did, loss of mental faculties came in first. In every study we did, loss of control came in second. In our first study, we had extreme pain, and it came in at number 3. And then the research team said, but why have we got extreme pain on this list? If someone's in extreme pain, they should sue their doctor, because there is no excuse for a terminally ill patient to be left in extreme pain. And I'll come back to that. So we changed it to the option to physical pain. And in the second study, it dropped down to number 6. And in the third study, it dropped down to number 8. People often think that pain is the major issue. And in every study we did, death itself came in last. People were not afraid of dying. They were afraid of loss of mental faculties, control, independence and dignity, and being a burden on their families. Those things were of much more concern to people than death itself. And as I said, even pain. So what is the reality about loss of mental faculties? Well, as shown in the previous slide, it's the biggest fear many people have, not just in relation to terminal illness, but even in relation to growing older. But what is the reality? Well, approximately 8% of people 85 plus have dementia, but that means 92% don't. Approximately 20% of people aged 75 plus have dementia, which means that 80% don't. And approximately 40% of people aged 90 plus have dementia, which means that 60% do not. But older people are often treated as if they do have dementia, and their fear is real. So advanced care planning can help to address their fears and concerns, your fears and concerns, my fears and concerns. The health and personal care mechanisms available to us are that a competent person can write care-related wishes and values in an advance directive. They can appoint their own substitute decision maker for a future time of loss of capacity. Usually that's a trusted relative or friend, but it can be someone that you have, well, we'll talk about who it can't be in a moment, but someone you trust is the main thing. Someone also tough enough. I've appointed someone who's tough enough to stand up to medical practitioners if they're not following my advance directive. Most states and territories in Australia also have legislation for who can make healthcare decisions if no one has been appointed by the person themselves. The important thing to note is that none of these mechanisms come into effect unless or until the person who made it loses decision-making capacity. And if they don't lose decision-making capacity, then it doesn't come into effect. So what are the overarching principles of advanced care planning? A competent patient who has the right to accept or refuse any treatment, even life-saving treatment. Oh, sorry, that's gone to the next screen. I don't know why. Here we go. A competent person over 18 can appoint someone to make decisions about medical or dental treatment or personal and lifestyle decisions on their behalf in case they lose the capacity to make their own decisions. There's different terminology in each state and territory for what that person is called, and in New South Wales it's called enduring guardian. The person appointed has to be at least 18 years of age, and as I said previously, is usually a trusted relative or friend. In most states or territories, it can't be the person who at the time of appointment provides medical treatment, care, accommodation services, or support services for daily living to a person on a professional basis. So what does that mean? That means that if someone is, if you're have a care package and someone is coming in from a care organisation, you can't appoint them as your enduring guardian. But if someone, a family member, is providing care to you and not on a professional basis, yes, of course you can. So what happens if no one has been appointed? So let's think about this scenario. So we've got a 55-year-old woman. She's been diagnosed with motor neurone disease 6 months ago. She hasn't written an advance directive and she hasn't appointed a substitute decision maker. She's taken unconscious to hospital after a car accident. She's now stable, but she's still unconscious, and decisions are needed about her medical treatment. Her husband is listed as next of kin on her previous hospital records, but they've been separated for many years and they don't see each other very often. For the last 5 years, the patient has lived with her same-sex partner. The patient and her husband have 2 adult children, a son and a daughter. Her son has enduring power of attorney for financial matters, and her daughter has recently taken 3 months leave to care for her mother full-time. All 4, plus the treating doctor, are present at the patient's bedside. So who do you think about this, who is legally entitled to consent to her medical treatment? Is it her husband? Is it her partner? Is it her son? Is it her daughter? Or is it her treating medical practitioner? So what does the law say? There is a specified order of authority in the legislation for who can make healthcare decisions, including refusal of treatment, if you haven't appointed your own person. In New South Wales, it's called person responsible. Now, it's the first readily available of a spouse, including de facto or same-sex partner, provided the relationship is close and continuing. If there is no spouse or partner, it moves to a non-professional carer. And as I said previously, that doesn't mean a staff member of a care provider. Usually it would be whoever was the carer before the person went into the care program. In fact, it's often a younger daughter or daughter-in-law. In one case in New South Wales, a woman had 3 children whom she hardly ever saw. And she had a next door neighbour who used to come in every morning and help her out of bed and put her washing on, take her to the doctor. When the woman lost capacity and the children started making decisions that the neighbour knew she wouldn't want, the neighbour applied to the New South Wales Guardianship Tribunal and she was deemed to be carer under the meaning of the Act, the person who has the day-by-day care of the person. If there hasn't been a carer, then the person might have had a sudden heart attack or stroke. No spouse, no partner, no non-professional carer, then it's close relative or friend of the patient. Now, as I often say to people, if you reach that point, you could have half a dozen people having a Barney over the bed. Don't leave it to chance. Please don't leave it to chance. Appoint someone you know and trust who's strong enough to stand up and argue for your rights. So having told you all of that, now, in the case of the woman who's waiting to have some treatment, now who do you think has the authority to make her decision? Now, I can't see you and talk to you, but what I can say is it is the partner. And the reason it's not the spouse is because it says, provided the relationship is close and continuing. And even though the woman and her husband never got a divorce, their relationship is not close and continuing. I told you before, about 5 years since they've even seen each other. So it is her partner. But if she didn't have a partner, it would move to non-professional carer. And we know that her daughter has just taken 3 months leave of absence to care for her mum full time. Nevertheless, it is still the partner with the daughter also caring. So when does a person have capacity to make a decision? This is really important. If you want to write an advance directive or you want to appoint a substitute decision maker, you need to have the capacity to do that. However, the person is presumed to have capacity unless proven otherwise. I don't have to prove to you that I have capacity. I have capacity unless you can prove that I don't. Now, a person does have to understand the nature and effect of the decisions to be made. I did have one very elderly lady come to me with her advance directive for me to witness, because I'm also a JP where I live. And I took the document from her and I said, tell me what you think this document's about. And she said, well, it's about what treatment I want or I don't want if I can't speak for myself in the future. I said, yep, that's what it's about. And I had a look at it and I said, well, in here you said, if you're in a persistent vegetative state. What's that mean? She said, well, it means I'm unconscious and I'm breathing and stuff, but I might even have my eyes open, but probably never be conscious again. Close enough for the purpose of the exercise. And I said, well, you've said if you're in that condition, you don't want CPR. What's that mean? She said, well, if my heart stops, they're not going to push on it to make it go or give me a shock to make it go. I said, then what would happen? And she said, well, then I die, but I'd rather die than be like that. She understood the nature and the effect of her decisions. I had no problems helping her complete and sign her documents, and she did it without any coercion or pressure or influence from others. And that's something we all have to be conscious of. But the person also has to be able to communicate their decision in some way, and not necessarily by speaking or writing. Body language may be adequate. For example, nodding or shaking their head. I helped a man in the PA spinal unit in Brisbane to complete his advance directive, and all he could do was nod and shake his head. And he absolutely knew what he wanted and he could make his wishes clear. So let's think about what incapacity is. Well, it's not ignorance. If you haven't been given adequate information, it says nothing about your capacity. It might say something about the person that gave it to you, but it doesn't say anything about yours. It's not eccentricity, cultural diversity, or having different ethical views. It's not communication failure. I've seen some woeful communication in healthcare situations. Incapacity is also not having a diagnosis of dementia. It depends on the level. If you have mild dementia, you usually would still have capacity. Moderate, you might have fluctuating capacity. After a good night's sleep, you might be fine. Later in the afternoon, you might not be. Severe, usually you wouldn't have, but you could still perhaps indicate when you don't want something, like having a peg tube inserted, for example, if you're having swallowing difficulties. And let me tell you that making what someone else thinks is a bad decision is no evidence of incapacity. You can make your decisions for good reasons, bad reasons, or no reasons, and you do not have to tell anybody what your reasons are. And disagreeing with your healthcare provider is no evidence of incapacity either. In some ways, I think it could be the opposite. So let's think about where you should keep your documents. Well, you need a copy easily accessible at home. And if you're in a care program, not only should they know where your documents are at home, but they should also have a copy. So the person you've appointed as your substitute decision maker needs a copy. Other family members, if you think that they're going to be supportive of the person you've appointed. Your next door neighbour. You know, if an ambulance gets called urgently and your neighbour has a copy, they could bring it out if nobody finds your other one. A copy in your GP file. On admission to a community care program or hospital or residential care, a copy should be placed in your client record, and I think Anne will tell you a bit more about that, to guide care plans and be available for subsequent admissions. A copy with your local ambulance service if they accept them. Now, that old lady I told you about before, she had hers in a plastic sleeve, blue tacked to the front of her fridge. She was determined no one was going to miss hers. And you can upload copies into things like My Health Record. Now, I just want to say a little bit about voluntary assisted dying. As you would know, I'm sure, because you're here in this webinar, all states in Australia have passed VAD legislation, and New South Wales legislation will come into effect on the 28th of November. Fortunately, after 25 years of a Commonwealth piece of legislation, the Draconian Euthanasia Laws Act, which prevented territories from developing voluntary assisted dying, that legislation was recently overturned. Yay. And the ACT has already started developing a bill. The NT hasn't started yet, which is interesting given that they were the first place in the world, not only in Australia, but in the world, to pass legislation that allowed both physician-assisted suicide and euthanasia. Now, Victoria was the first state in Australia to pass VAD law, and it has the most conservative legislation in the world. It's narrow in scope. It includes 68 safeguards, with the other states slightly less restrictive. I think Queensland is the best so far because of expected time to death. Most of the other states say it's 6 months. Your death is expected in 6 months unless you have a neurological condition, when it becomes 12 months. In Queensland, it's a blanket 12 months. So people who don't have a neurological condition, who are 12 months out from predicted death, would have access. And assistance is primarily intended to be prescribing medication for the person to take themselves, unless they lack the physical capacity to do so, or the relevant medical practitioner deems it not appropriate for the person to self-administer, in which case the doctor can administer. So just to round this out, voluntary assisted dying and advanced directives, do they go together, or do they go together? Well, they don't in Australia. All voluntary assisted dying laws in Australia, I believe, discriminate against people with dementia because they don't allow requests via an advance directive. And if you look at the terminology in all of the legislation, not only does it say a current repeated request, but it says that the person has to still have capacity right up to the very last moment of receiving the assistance. It's interesting that the Netherlands legislation does allow requests via an advance directive, but those requests are seldom honoured. Now, I talked about this with one of my colleagues in the Netherlands, and she explained that before their legislation was actually passed, and it actually wasn't passed until after the Northern Territory legislation, but before that, the doctors would still provide assistance, but they had a defence in the law called force majeure, which meant I had no other way of relieving my patient's suffering. And they were hammered by anti-euthanasia people all over the world. The people in the Netherlands really copped it before. And so once their legislation was passed, the doctors were very, very particular about meeting the conditions of the legislation. And while it does allow requests via an advance directive, it does say a current repeated request. So it's quite ambiguous over there. So the requests in the advance directive are seldom honoured. The problem is that people over there are, particularly all the older people, they're learning that it might not be honoured in their advance directive. So they're asking to go before they really want to. So I guess the questions that we all need to be thinking about is, should voluntary assisted dying be available via an advance directive? So that brings me to the end of my section. I think somehow or other I have to say stop sharing the screen, but
that's right.
There we go, up there. Right.
Okay.
So,
thank you.
Over to you, Shane.
Thanks, Colleen. Well, there was I only noticed one question in the chat. If anyone has a question that they want Colleen to answer, perhaps you could put it in the chat now while I just read out this question. And if not, you can keep it to the end. We can hear from Anne and then do all the questions at the end. The person who asked the question said, many people have no relatives to appoint as guardian and are worried about appointing the state system as guardian. What is the best alternative?
I would be inclined not to appoint the state. My advice is normally that, you know, if you've got a group of friends, or some younger, some older, perhaps you can appoint two or more. Even if they're not relatives, they actually don't have to be, that you can ask, you know, each other. I have enduring power of attorney, sorry, Queensland and New South Wales are different, enduring guardianship for some of my friends. And fortunately, I have a son and a daughter who are both happy to have my appointment. But for those who don't have, you know, you've of course got to think about, well, you know, if they're the same age as me, how will they still be here? But if you appoint several, and you can do that, and you can appoint them jointly or severally, in other words, they have to do it together, or they can do it, anyone can do it. And I would be making the latter decision. But make sure it is someone who you trust, someone who really understands what you want and is tough enough to stand up and argue for your rights. Thank you.
There has been another question. Should we have both an advanced care directive and enduring guardian?
Absolutely. Absolutely. Because you won't be able to consider in your advanced directive every possible situation that could come up. You can give some general instructions if I'm ever in the following conditions, but there might be something that has come up, or there might be some new treatment that could offer some benefit, but you need to have discussed that with your enduring guardian so that they know whether you would want to have that option. And also my enduring guardian, I just pity any doctor that takes her on. You know, she will be out there fighting for me to make sure that my wishes in my advance directive are honoured. And we've spoken at length about it. She knows all the ifs and buts and maybes of what would happen. If this, if that. In Queensland, by the way, if you cannot speak for yourself, but the projected treatment or proposed treatment can restore you to capacity so you can make your own decisions, your advance directive doesn't apply. Now, that's interesting because it's the only state in Australia where that is the case. But your enduring guardian could have that option of if you have, if there is something they're proposing. I'll give you a quick example. In one case I used to use as a case study was a man who'd been diagnosed with AIDS 5 years previously, had been on antiretroviral treatment, was doing quite well. And in his, when he was first diagnosed, he completed an advance directive saying if he was ever in a terminal, if he ever had a terminal illness, he didn't want to be treated. So he has developed pneumonia. If he's given antibiotics, he can be returned to where he was prior to getting the pneumonia. And so in Queensland, his document wouldn't apply. But, you know, you need to think about things like that and say to the person who's your enduring guardian, or put in your advance directive, unless it can return me to capacity so I can make my own decisions. It doesn't matter that it might sort of bring you back to still be in a vegetative state or something. Most of us would really rather go, wouldn't we? So, yeah.
And Julie has asked, would you recommend an advanced care form to complete? As in, I think obviously you're definitely recommending to have one, but is there a particular one? And I should, before you answer, I should say that we actually, Colleen, Dying with Dignity for many years has sent out to people, and it's still available on the website, one that Colleen, you designed that one, didn't you? I think probably prior to the New South Wales Health. So if you go to our website, when we send you a pack, it has both. But is that still, what would be your recommendation, Colleen?
Well, I always tell people now to go to Advanced Care Planning Australia and go to New South Wales on their website. I've designed many over the years. I designed one for LGBTI people. I designed one for use in residential care. I still have them, and if you ever want any copies, Shane. But, you know, some people have decided that other forms suit them better. So, yeah, and absolutely not. Somebody just came up and said, is it enough to have it in my will? When do people look at your will? After you're dead. Too late, she cried. No, it's not okay to have it in your will. I don't get upset about this, do I, Shane?
No. So look, we've still got a couple of questions, but I'm just looking at the time. I think it might be good at this point. I won't forget them. And I know that there was someone who had their hand up a minute ago. So, we'll come back to you after, but I might hand over to our next speaker, Anne Meller. And if you'd like to share your screen and start your presentation, that'd be fantastic. Thank you.
Thanks, everybody. Can you hear me?
Yep.
Excellent. Well, thanks for the invitation to speak tonight to Shane and Penny, and thanks to Colleen for setting the tone. Colleen's a really hard act to follow. We've done a few tag teams before, haven't we, Colleen? So I'm been asked to sort of give a bit of a health perspective. So I'm not representing my health district. I've just worked in this area for about 20 years now in a dedicated position, assisting people in the community. So I'd just like to talk about a few practicalities. If I can progress my screen, I'm a bit the same as Colleen. There we go. So what I'm going to do, I've got a lot of slides, but it's more just to keep me on track and prompt me to where I get up to in conversations, because I don't want to kind of rabbit on too much or get off track. So I'm going to refer to the National Framework for Advanced Care Planning Documents that was revised in 2021. So it's a national kind of aspirational document, probably more geared at policymakers, but it provides just a framework for having the discussions. It also provides some definitions and some ethical principles about advanced care planning. And as Colleen says, what we'll do tonight is probably just go back and forth between all these things. Having that advanced care planning conversation is very important while you're able. And as Colleen has said, as a result of that conversation, some people will develop either an advanced care directive or an advanced care plan. But what I'd like to just focus on now is how we access those documents. I'm just going to sort of minimize everybody because I can't see. Sorry. How we access those documents, because often that's been a bit of an argument, is the rotten document's never there when you need it. So we have made some progress in that regard in recent years, or in many years. So, and in doing that, I'll probably just come back to some of those advanced care planning documents, because I've seen a few comments cropping up there, and a lot of that comes to the detail in terms of the difference between advanced care plans and advanced care directives. So just back to accessing them. So most health districts in New South Wales now, with the exception of Hunter New England and St Vincent's Network, I think, they over the last 2 years, when, we know there were, this other thing called a pandemic going on, they released in electronic medical records the opportunity for advanced care planning documents and to focus on end-of-life care. How do we identify people? So there has been a body of work in that area. But even if like a local hospital doesn't have electronic medical records, they might have a paper file, or they might have a hybrid system. There should be some ability to store your documents there. And I'll just go through your options in that. So if you're admitted to hospital, you should be asked, and I'm taking this from the screen, from the admission tool, do you have an advanced care directive, a plan, appointment of enduring guardian, or other advanced care documents? So we should be asking that, and was it provided, yes or no? And we might say, well, just bring it in, or get someone to bring it in next time. But if you provide a copy, if you provide a copy, we can upload that, or there's usually a place within a hard copy to put on a paper file. However, it is optional. It's your document. It doesn't belong to the hospital or the doctor. So there is an option there. And as part of a local study, we developed a kind of a controlled process to upload these documents, where we ticked and crossed and checked all the balances about the documents we were uploading. So if they were used later, they could be trusted. We also created an alert so the admitting doctor and team were aware of its existence. Now, this is different to the My Health Record that the Australian government links Medicare, the tax office and Centrelink, but we can view that in a site called Health eNet. Now, the local study that I mentioned, we've got a protocol paper, but our findings haven't been published as yet, but we've done quite a bit of work with outpatient services across 5 sites in 2 local health districts. So what do we do with that bit of paper when we get it? So, you know, as Colleen said, validity is very important. What makes a valid document? We check, we get 4 levels of identity, and I'll come back to validity in a minute. So we check for the 4 levels of identity that we've got the right person and the right document, and then we classify that as either a directive, enduring guardianship, or a plan. We assign that to the admitting specialist, or if they're in the community, the service director of that community can delegate that authority. And then we email it off to medical records to upload. They deal with a lot of health information, so it's very important that it's in the right place. They're like librarians. You've got to put it in the right spot. Now, validity, as Colleen mentioned, there are elements to how do we know an advanced care directive is valid. And indeed, New South Wales Health has a mandatory policy or a treatment manual in regard to consent to medical and healthcare treatment. And it's got a whole section on advanced care directives. So mandatory policy for New South Wales Health staff, we need to follow that policy and refer to it if we don't know. So there's no surprises here that a directive is valid when it's made voluntarily by an adult with capacity. It's clear and unambiguous and was intended to apply to the situation. And there have been 2 cases where Hunter and New England district have actually approached the Supreme Court, because another argument as why we shouldn't be following them is because they're not legally binding. We don't have to. Well, Hunter and New England actually went to the courts, and because the judge ruled on the validity of those documents, we can now say, yes, they are legally binding and health professionals should be following them. So in practice, when we get that, you know, glorious bit of paper and we want to tick off that, yes, what do we know about this validity, I'd just like to reassure you that capacity is assumed. There needs to be something fairly obvious telling us otherwise, but we don't go hunting around to try and fail people we're not testing capacity. So that's the argument for witnessing, even though it's not mandatory, but it does give us some assurance if we want this document to be followed that you did that of your own free will. It's clear and unambiguous. Now, often documents are quite vague, saying, don't hook me up to machines, and kind of we get the sentiment, but well, when and what type of machine? And do you mean a drip or? So there are some machines that are quite helpful that aren't too intrusive at all. So is it clear and unambiguous? Now, was it intended to apply to the situation at home? So does it apply now? Is the person now at that irreversible point? Now, one directive is the New South Wales, the Ministry of Health did develop making an advanced care directive, and part of our study, we evaluated that with patients, carers and the clinicians involved. So we did an evaluation and they upheld basically the recommendations we made. So that document does get people to say, if I'm at an irreversible point and I'm not likely to get better, what would be acceptable to me? So is the person there now? So we found in our clinic studies, often people were seeing the doctors, they were seeing specialists, and they completed it. They handed it to their doctor while they were still quite well and capable. So it's not going to apply for quite some time. It's not going to kick in until you can't make your own decisions. So we need to check it each time you come in, because now it's uploaded. You might just come in with a sore toe, and we're not going to refer to your directive because you can still make your own decisions. So it's one of our screens, for instance, different hospitals will have different looking type screens, but we can see here that this patient has a guardianship document. They've had some discussions. They also have an advanced care directive, and that advanced care planning form that they complete when they come in has been completed. So there are tabs. There's now an ability there to see that kind of information. Equally, on a different, like a summary screen, we can see there's an alert here to say this person has enduring guardianship with directions or an advanced care directive. And up in the right-hand corner there, Health eNet, that's the link to the My Health Record site, where if a patient's really saying, I've got it, it's online, I put it in with My Health Record, we could go in there with their permission and have a look for that. Now, what people get really confused about is medical orders and patients' kind of documents. So your advanced care directive, a plan, an enduring guardianship appointment, they're going to inform the development of adult resuscitation plans, treatment plans, terminal care pathways and plans, but only a doctor can complete those. So sometimes I'll hear people at home and they'll say, oh no, I've got an advanced care directive, the doctor did it in hospital. And then when I go and look, no, they've actually had a resuscitation plan, and that ceases once you leave hospital. So that needs to be rewritten when the doctor comes, when you get readmitted again, because you might get better and not need that necessarily. So that they inform those, and an individual can't sign a resuscitation form. It's a medical order. So that's directives. So Colleen's spoken about advanced care directives. We've mentioned enduring guardianship. I just want to talk a little bit about directions in enduring guardianship before we get on to advanced care plans. So enduring guardianship is really important. It's the legislation that tells us who we need to talk to about your health matters. I did notice a question there, is that the same as power of attorney? And I deliberately left that slide out because I keep thinking everybody's got it. Enduring power of attorney and power of attorney only relate to financial matters, shares, real estate transactions. Enduring guardianship is appointing someone to make your health and lifestyle decisions when you can't make them for yourself. So you can appoint someone and they're given different functions, or they can make different decisions about where you live, what services you receive, what healthcare services they can give and withhold consent to medical treatment, and they can decide on your accommodation. Obviously, it's important that they can talk to your enduring power of attorney, or you might appoint one person to do both those things. So enduring guardianship is in New South Wales. It's someone you appoint. It needs to be witnessed by a solicitor or clerk of the court. So when we see that appointment, we want to know we're talking to the right person and what functions they actually have. Now, in a national survey done by the Advanced Care Planning Australia, they found that for 27% of people who had appointed a substitute decision maker, this is nationally, 27% of them had actually included directions about the use of life-sustaining treatment in the event that they couldn't speak for themselves. Now, I think often I'll get asked by people, can you go and do some kind of plan that would reflect what we think the patient wanted now that they've lost decision-making capacity? And if I ask for an enduring guardianship appointment, I find often there are directions in there as well, and people have actually forgotten that they're there. So that's giving us very strong guidance about what that person would want. So it's important to get a copy of enduring guardianship and certainly look for directions, because it might be all they have. They mightn't have done a directive. And I've also seen the point where a lot of people, they don't have someone they can appoint as a guardian, and I'd be strongly recommending they do an advanced care directive to say what they want. So that's directive. Sorry, I've rabbited on about that. Advanced care plans. Now, the devil's in the detail here, because an advanced care plan the word gets touted about a lot, but it's basically a document that talks about your preferences, but it doesn't meet that common law requirement to be sufficiently valid to be an advanced care directive. And it might be done by a person who's just saying, this is what's important to me. I don't really want to write a bossy instructional directive. I just want to tell you that I don't like lavender on the pillow or something, or just very personal things, or the kind of music they like. If, so to listen to that, they can't speak for themselves, but the person themselves can do that, or it might be someone acting on their behalf. So it's not a directive if it's done by somebody else. Equally, an advanced care plan done on behalf of someone else is really good in terms of providing guidance, but they're not legally binding. So it might be oral or written, but we prefer something written. And you can't just name who you'd prefer as your decision maker. If you want someone to be your decision maker, get them appointed and get that appointment witnessed by not a JP, but a legal professional. So some people I might be talking to, they'll just say, I just want to write a nice little letter, little Word document. So we'll start crafting a bit of a story about this person, about what they're doing and who they might want to make their decisions. And they'll detail a little bit about their own history and story. But sometimes in the process of that conversation, they'll say, but I'm 105, I've had a good innings. If I collapse now, I really don't want to have CPR. That's when they're starting to say there are certain things that I want, and I understand what CPR is. I haven't just got that from watching telly. And they're starting to state quite clearly about what they want and what's important to them. So that's where I might be writing a plan, but then I'll probably rebadge that as a directive later on. And it's us, when we receive the document in health, we determine whether it's a plan or a directive. Now, remember that the treating doctor determines what's the most appropriate treatment to offer. And you might indicate that for you, CPR would be acceptable. It'd be okay, but you or your family can't demand it. It's up to the treating doctor to determine what's appropriate for you. So just remember that plans, you might outline when you're able what's important to you. That'll just give a bit of guidance, or someone else might write that on your behalf, or it could be following a consensus meeting with your service provider or GP and substitute decision maker, anticipating deterioration and how we might best manage that event when that happens, and what services are available, say, to come into your home or residential care. But often people are in between that capable, incapable area, especially when they're acutely unwell and hospitalised. So we often need to just give them some support and help with decision making and communicating their preferences. So we will try and reverse what's reversible and then review them when they're stable. And we call that supported decision making. Amongst other, supported decision making is a whole area in itself, but it's not a black and white about capable, incapable. It's all the onus on us to help people to make decisions on their own behalf. The same study, the Advanced Care Planning Prevalence Study, also found that that national study that 30% of advanced care directive documentation from aged care had been completed by someone other than a competent individual. So they're talking about advanced care directives here, and it's not consistent with the law. An advanced care directive needs to be signed by the individual, not someone else. So you might find here that a family member or somebody else is signing, don't do CPR, don't do this, don't do that, and they don't have the authority to do that in New South Wales. So you're putting yourself at risk. So whatever document, we often get documents from nursing homes that'll say advanced care directive. It's clearly signed by the family member. The person's clearly had a very long-term history of dementia and is now in a mute state, and it was signed 3 weeks ago. They've been mute for a long time and very disabled. It's clear that that wasn't done by a competent adult. So we'll be classifying that document, no matter what heading it's got, as a plan. So I do say to health professionals, whatever document you get, just check it to see if it meets that requirement for capacity, specificity and currency. Obviously a witness helps, but if it's just going to guide or document a consensus, we're going to call that a plan. And as we know, there's the great safeguard with the Guardianship Act that's there to support people who are very vulnerable, who can't make their own treatment decisions. And as Colleen said, the first person we should be looking for is there an appointed guardian for this person? If we don't ask that question, we immediately start jumping, looking around the bed. Who's standing there? Is that the spouse? Is it the carer? Is it any other relative or friend with a close and continuing relationship? And depending on the level of treatment required, then the Guardianship Division of NCAT, which is the New South Wales Civil Administration Tribunal, might need to be contacted to provide consent. If you need some help, then Planning Friend of Life is part of Life Events New South Wales. It's all classified there into 8 categories of when you might need a bit of help. So Planning Friend of Life will lead you to guardianship and advanced care directives in New South Wales. Also, as Colleen said, Advanced Care Planning Australia is a great site to start. They have webinars, they have training, and QUT, End of Life Law in Australia, has great information about all the kinds of things about end of life law in Australia. And for clinicians who might be on board, they run a great online module on end of life law for clinicians. So on that note, I'll stop. I haven't been able to see any of the chat questions as they've come up, but I'll escape.
That's
I haven't gone over time.
No, we're looking good. I mean, we're obviously happy to go beyond 6 o'clock. So I have copied all the questions that have come through in the chat. And if because of the numbers of people, when we had over 300 people actually turn up and take part, it would be really great if you could put questions, if you've still got questions, into the chat. And if you don't know where the chat is, if you look down the bottom of your screen underneath the pictures of everybody, there's mute, stop video, security, participants, then there's the word chat. If you click on that, it'll open up a white panel and you can see there's conversations going on. So I think I'll just run through them in the order, if that's okay. And so I think, Diane, you're one of the people who had their hand up, but if it's okay, if you can put your question in the chat would be better. Okay, well, if we've got time, I'll come back to you because you are showing up on my front screen there. So, but we'll just get through the questions that have come through in the chat. We've answered, so the first question that came in after the two that you'd already answered, why wouldn't you recommend using the public guardian? I think, Colleen, that question came in when you mentioned that. Do you want to just briefly say why you prefer not?
Yes, sorry, Shane, it's just that ideally you want someone who knows you, who understands your values. The public guardian, staff can change. They might not exactly understand what your document means. I guess if you've absolutely got nobody else, then okay. But also the public guardian, you know, as I said, how's that person going to make a decision if your documents are not saying precisely what meets the current situation? Yep. Somebody might have to make a decision, and someone who knows you well. If you don't have any relatives or family members, or, you know, I don't think there's anybody here who wouldn't have a friend, but you might, as I said, your friends might all be in the same situation as you, and they might not actually want to take on that responsibility. But well, you know, if you've absolutely got nobody else, then I suppose you could ask the public guardian, but it wouldn't be my recommendation.
Thank you. The next question was, if I have made an advance care directive whilst in good health, and then I have a stroke or something which causes me to lose capacity, can my advance care directive be used to end my life?
Do you want me to do this, Anne?
Go ahead.
Yeah, right, okay. Your advance directive can never be used to end your life. Your advance directive is about what treatment you do or you don't want under certain circumstances. Now, if, for example, mine says, if I'm in the terminal phase of a terminal illness, I don't want CPR. I don't want artificial nutrition hydration. I don't want artificial ventilation unless I'm gasping for breath and to make me comfortable as I die. But your advance directive doesn't allow someone to provide you with voluntary assisted dying. And I did make that point at the end of my presentation, that no state or territory in Australia will allow voluntary assisted dying to be honoured through an advance directive.
Great, thank you. And I'm just in the process of, I'll just copy this next question so I don't miss any, because already there's quite a few that have just come in. Give me 1 second. Okie doke, back up to there. How often would you recommend an advance directive be reviewed? And I think a few people have asked a similar question, but that's how it was worded.
Sure. I used, on the back of the one I designed originally, which it's still got on the back of it, it says every 2 years unless your health condition changes. Right. And then I say, you know, every 6 months. Yeah. But if it's like, if there is no law that says it has to be updated, you could have made it 10 years ago. And if there's no evidence that you've changed your mind, it still holds. But the longer it is since you made it, the more leniency there is, or the more space there is for family members to say, oh yes, but that she made that a long, long time ago and she's changed her mind since then. So if you only made it last year, and on the back of the one that I had, all you had to do was sign and date it, and it says everything in this is still exactly as I want it to be. The more recently you have signed that and dated it, the more weight it will have if family members are arguing against it.
It is recommended that people might review it after they get a new diagnosis, or if they've been in hospital or their conditions changed. And
Yeah.
but equally, some people find this very confronting, and it's a part of their life they don't want to do. They do it when it's done. It's like the insurance policy. It's out of the way. It's done. They can get back with their life. So I don't know that I'd want to be looking at it every 6 months. And as Colleen said, there is no legislation that says it's got to be done every so often, you know, every year on the year or anything like that, just as your circumstances change.
Yeah. Well, the next person said
There's no sunset clause. It's not going to
No.
run out.
The next person said, I have a 10-year-old advance directive. Would that be too old? I think that's probably getting a bit, but it depends what it says, I suppose.
I was going to say, it's not too old if it still reflects your current wishes.
Yeah.
But as I said, I would write on it. I have reviewed this document in February 2023, and it still reflects my wishes.
Well,
you know, don't leave it to somebody else to argue, oh, yeah, but in between she changed her mind.
Yeah, no, that's great. And look, I've thought of something because it came up when you were talking, Colleen, and a good reason to potentially update them for those people who want to update them. How do you think, you mentioned I only want ventilation if I need it to be kept comfortable. How has COVID affected people's directions in an advanced care directive? Do you think that people potentially have stuff written in advanced care directive that obviously none of us anticipated COVID? When I wrote mine a few years back, we hadn't had COVID. How has that made any difference?
Well, it wouldn't make any difference to mine, because my directive, the one I designed, says if in the opinion of my treating medical practitioner, I'm in one of the following conditions: the terminal phase of a terminal illness, a persistent vegetative state, a permanent coma, or I'm so seriously ill or injured that my life could not be sustained without the continued application of life-sustaining measures, then I do or I don't want the following things. So I spelled out very clearly what sort of circumstances might apply. But my sister, who's 82, did get COVID and has now got long COVID. And I noticed that her directive said that she never wanted artificial ventilation. So I spoke to her about that the other day, and we now have an appointment to update her document, because I said you could be terminally ill but struggling to breathe, and just with the help of a little bit of ventilation, you can die in comfort. So, you know, people need to be able to make it clear that while they don't want particular things to prolong their dying, and it's good language to develop, folks, is I do not want anything that will prolong my dying, but I do want whatever I need to keep me comfortable as I go.
Great. This question, I'm pretty sure, has been answered. Is an enduring power of attorney the same as enduring guardianship? Anne has answered that, and no, they're different. The enduring guardian is the one to do with health decisions, whereas the power of attorney is the financial. This question says, I had an ambulance person tell me I have to redo advanced care directives yearly. Was that correct in New South Wales? You've already answered that one. So I'm reading these for the first time. So
it reinforces it, Shane, so it's fine to read them again. And no, you don't have to update.
And we used to do something called an ambulance plan for people who were at home and expected to deteriorate if the family didn't know how to manage medications and things. And they're still in use if there's particular medications that might need to be prescribed for the ambulance to provide. However, my understanding is the ambulance service, they will ask, does the person have an advanced care directive? And they will look at that and make a decision then about what's treatable and how they can manage. So if you have it and you've either got it blue tacked to the fridge or keep it with your medications, that they will refer to that if the person can't speak for themselves. Obviously, if you're saying, I can't breathe, can I please go to hospital for some oxygen? They're not going to look at your directive, that you can still provide your own consent to treatment.
And which one is more powerful, advanced care directive or enduring guardianship? Again, I think you've answered it already, but maybe just quickly revise that for some.
I mean, again, it depends. Some people will do enduring guardianship and they'll put all their directions in that appointment, and others will say, please refer to my advanced care directive. Now, one lawyer said to me once, it's better that they do the advanced care directive separately, because if there is then a challenge that goes to NCAT, to the guardianship division, that the whole document, and say that gets overturned, that enduring guardianship appointment, the directions that were in that appointment go with it, whereas the advanced care directive might deem to still be valid and it will apply to the person. But I think, I just think enduring guardianship, it's something here that we don't think to ask, to look for. And often people haven't done an advanced care directive, but they have got directions in enduring guardianship appointment. And I think that's really helpful. And we just don't think to look for it. It's just that other appointment. And as you say, everyone confuses power of attorney and guardianship. And you know, we've had the Guardianship Act around since 1987, but we still don't get it right. Enduring guardianship since 2001. So,
okay.
Yeah.
This question again, I feel like that Anne answered it. What's the difference between advanced care directive and advanced care plan?
yeah.
You want to just quickly recap that? You did.
So a directive will meet those criteria for capacity, specificity, and currency. There'll be no question this is what the person categorically wants, and we haven't got a question about it. A plan is more going to be about guidance, about kind of the preferred things you might like, but there tends not to be any treatment limitation in it. In New South Wales, if someone's not appointed as a guardian, they don't have the automatic right to consent to withholding and withdrawing treatment. That's a really fine, tedious point. So but that's why those advanced care directives signed by family members aren't valid, because they're not appointed to make those decisions.
But also, Anne, isn't it the case that an advanced care plan, which hasn't been witnessed, hasn't been written correctly, it's not legally binding anyway? It's advisory.
The aim is to give guidance. And some people don't want to do a bossy directive. They don't want to, they're sort of, they're nice.
Oh, do them, folks, do them, please do them.
Okay, this is a different one. Is all this possible for permanent residents or only for Australian citizens?
Permanent residents would be eligible. Yeah, why not?
Absolutely. If you go to hospital and you've got your documents, they're going to be looked at, aren't they, Anne?
Yeah.
So do copies of these documents need to be certified?
It's preferable that an enduring guardianship appointment we've got a certified copy of that. So people, when they get that, they often ask to have some certified copies done by the practice. But advanced care directive, no. We often get the originals and then do photocopies and scan it in as PDFs and things.
I was just about to say they, with the guardianship one, unlike with the enduring power of attorney, enduring power of attorney for finances, you usually have to make multiple copies of that because some has to go to the bank and everybody else. With enduring guardianship, you'd probably only need to make say 3 or 4 copies, particularly if you've appointed 2 or 3 family members, and you can appoint them jointly or severally, as I said before, so that you might say, I want this person to make my decisions, but if she's not available, then move to the next one. Or you might say, oh, I want to appoint all my kids and there's got to be consensus decision. Don't do that. If you've got, you're going to have a Barney over the bed and nothing will happen. But if you do want to appoint, one woman said to me, oh, I have to appoint both my son and my daughter because otherwise the other one will get upset. And I said, do they get on? And she said, no. I said, don't bother, you'll end up in the tribunal.
And this is a question from me because I did my advanced care directive and I appointed my partner as my enduring guardian. But if he, can't do it, can't carry out that thing, I made my daughter. But I'm pretty sure that I was meant to have a follow-up appointment with the solicitor, the lawyer, so that she could sign it. And I don't think that's happened. If I ended up in hospital and that document was used, would they honour it, or should I make that?
No, you should. I won't upload them until they've got all their signatures on them. Yeah, it's
all
not valid. Yeah.
So everybody.
And often families don't realise, and they go, "Oh, sorry, wrong page," or "I'll go to the solicitor and get that done." We don't want to be fussing around with that if someone's unwell. That we've ticked and crossed as much as we can prior.
And however, Anne, if someone came into hospital in this situation that Shane just mentioned, and if her partner wasn't available, And even though the signature had been on the document for her daughter, if she was the first available and readily appropriate
She'd be the person responsible anyway.
She'd be the person responsible anyway. So she would be the person who would make your decisions.
I mean, it's me nitpicking, but it is showing an indication of this is who the person wants. Yeah.
Oh, get it signed, but if you know, it's first readily available, and in Queensland, it's also culturally appropriate. Because some of the Indigenous people told us you wouldn't have a clue who's the right person to make the decision, and so our legislation says you can tell us.
Okay. What about a Medi Alert bracelet or necklace? You know, the no resuscitation type things.
The difficulty with that is, how do people know that it meets the situation you had in mind? I do tell people a little joke about the nurse who had NFR tattooed on her chest. They tell me on her back she had PTO. But that is a joke, folks. That is a joke. If a Medi Alert bracelet, you might have a bracelet to tell someone you're diabetic, or to tell someone, you know, something that does let people quickly give you the correct treatment. But you know, in and of itself, it's useless if you're wanting it to be your replacement for your advance directive. Sorry, Anne, were you?
Oh, I think it's not telling us when you don't you say I don't want CPR. Is that ever from today on? And what if you get a piece stuck in your throat and all those kind of things? So it's not really. Is it specific enough? You know.
No.
Yeah.
No.
Yeah.
No.
Okay. So maybe not. So again, this question is sort of similar, but it's slightly different. Does the directive have to be authorised by a JP? Now, I know that Heath answered a question. Can I just confirm what's in my head, and hopefully it'll clear it up for everybody else? The enduring guardian document has to be done with a solicitor, not your doctor, isn't it? It's a legal.
That's right. So and it's not a JP.
Not a JP. It is your lawyer or a lawyer.
Solicitor. Yep.
That's right. Solicitor. That's the appointing an enduring guardian. But an advanced care directive, is that with you? Does the doctor have to be involved with that, or can they just send it home with you and you fill it out and bring it back to him or her? What's the situation there?
It can happen whatever sort of relationship you have with your doctor. You can fill it out and give it to your doctor, or some doctors will refer to me and I'll say, look, they're really stuck on this whole, you know, whether they should have a certain treatment or not. And I say, that's fine. I'll talk about that next time they come in and see me in my rooms. So if they're querying some kind of possible treatment, ideally they've got a bit of an understanding about their conditions, and maybe there's a real fear there about something and it's not going to affect them. They're really not going to be, that's probably not, you know, people see, you don't want directives to be done out of a whole fear, you know, just apart from the lack of control at end of life. So if you've got a good relationship with your GP and you can write what you want, you can have a discussion, that's good. But otherwise, you can just complete it and take it into your doctor and say, oh, I've done this. And either you sign it, and then you can ask a neighbour or someone to sign it. They're not signing, assessing your capacity. They're just saying, yes, this was Colleen and I witnessed her signature and she didn't seem to be under any undue. And
I actually don't agree, sorry.
Because you don't have to.
No, I know, darling, we often don't. But we're good friends, so it's okay. Because on the documents, if you recall, on the ones that I designed, it had a page for the doctor to complete. And it said, I've discussed this document with Anne, and in my opinion, she is not suffering from any condition that would affect her ability to understand the decision she's made. So when someone comes to action that document, they don't have to think, did Anne have capacity at the time? Yeah. Because your doctor had said that you did. And this could be 5 years on or something. And family members might be saying, oh, no, she didn't have capacity back then. But if your doctor has signed the page, or I don't know, some of the documents mightn't have it anymore. But where it says, you know, I have discussed this document with Anne, and in my opinion, she is not suffering from any condition that would affect her ability to understand the decision she's made. It's binding.
Yeah. It's certainly, the New South Wales health document has a treating health professional can witness it, and or the doctor can sign and make a comment about felt that that person had capacity. But we're not going about doing capacity assessments or anything like that. There'd need to be something fairly glaring. If someone was signing a document and we thought, I don't think they know what they're doing, then we wouldn't be happy to witness it. But, and yes, it certainly does help verify when it's needed at the pointy end. I agree, Colleen. We're not disagreeing on that, but it's not mandatory.
Gee, aren't we? Oh.
It's just, well, some people will raise the argument that it's quite expensive to go to a doctor to get their capacity ticked off when it's already assumed within the law.
Great.
Yeah.
Thank you for that. The next question is, many residential aged care facilities promote SOC. I think that's statement of
choice.
Choice.
It's called statement of choice, and it's not nearly as good as an advance directive.
Yeah,
Yeah,
so yeah, they're saying that this questioner says many RACFs promote SOCs as easier to complete. That document is not legally binding, is my understanding. Can you just clarify the same?
And it would only be the same in a way, Anne, as the advanced care plan, wouldn't it?
Yeah, I haven't seen the SOC. I don't know what it is.
Well, it's called statement of choices. Usually statement of choices is made by someone on behalf of someone else.
Yeah,
you know,
so that's a plan then.
Yeah, and yeah, it doesn't have the same legal standing as an advance directive does.
No. It's kind of saying, look, it goes down the plan. We've had a discussion. This is what we think would be appropriate for this person, but yes, it's not binding.
Good, that's great. I think it's very clear. I think we're all going to go away with the idea that we need advanced care directives and we need to appoint an enduring guardian. This next one, what would the situation be if the family is adamant about overriding any directives from either the patient or medical officer?
Let me tell you a little story. Sorry, you're getting an echo? The advance directive is legally binding. It doesn't matter what the family says. But one young resident that I interviewed, he had a family. Sorry, I'm getting lots of echoes. Can you hear the lots of echoes happening? I don't know what's happening.
I think anyway. It was just Anne. Because she was off mute, but she's muted now. So you playing back through her computer.
Okay.
Yeah, keep going.
Okay, so nobody can overturn it. I realized as I went through that I missed one slide, talking to one of my slides, I think, when I was trying to flick through and find it. But in there, I tell you that nobody, not the person you've appointed as your enduring guardian, no family member, your treating document. If the advance directive has been properly made and meets the current situation, nobody can overrule it. And if they do, they are breaking the law. And that's why you need to appoint someone very strong to have your enduring guardianship to stand up to other family members, for example, and to make sure that it's your life, your wishes. You know, one time when I was trying to help someone complete an advance directive and I asked her who she would want to be her enduring equivalent enduring guardian, I'm in Queensland, but and she told me, and her son jumped in and said, oh, but Heather would want to be one. She would get upset if she wasn't appointed. And I very quickly told him it wasn't Heather's life we were talking about, it was his mother's, and whoever she wanted would be who she would have, which we did. He was very cross with me, but I'm okay with people getting cross with me. So yeah, nobody should, but that young resident I was telling you about, it was I think maybe an Italian family or something, and the woman had a heart attack and she was a very old, frail lady, and they screamed at him to give her CPR, and he knew she didn't want it, but he eventually, because he was young and in panic, he did what they said, and she died anyway, and he had nightmares for ages afterwards about feeling her bones crunching under his hands. He should never have done it. But when you've got a family screaming at you, you've got to be tough and stand up to them and say, she does not want this.
Yeah.
I don't get hot under the collar about this, do I, Shane? You're muted, Shane.
And you're muted. And I just jump in and say something. I'm Penny Hackett, who's the president of Dying with Dignity. I wasn't playing anything because Colleen and Anne are vastly more qualified than me to deal with these. Had a bit of personal experience with it. We don't live in a perfect world or a perfect health system. Sometimes people don't have these arrangements in place. If at the very minimum, even if you have an advance directive and an enduring, the most important thing is talk to your loved ones about what your wishes are. And there's no point having an advance directive and guardian if no about it. It can just lead to terrible conflict. Sometimes lasting damages family relationships. And if you do nothing else, have those conversations with your family and those close to you, so they know what you want. And it can be a difficult conversation to start. But in my experience, most people want to talk about it. And in families, it can be like a Mexican standoff. The parents don't want to upset children, and then the children don't want to upset the parents. And then once you start that conversation, it gets easier, and it can save an awful lot of trouble. You have your family having a fight over the intensive care bed about what you would have wanted. So
can I just say also, Penny, that if you're watching TV and there's something on TV that is relevant, grab the moment and say to your family who are sitting around you, what would you want under that situation?
Yeah, that's a good suggestion. Okay, we'll go back. Now, because Diane had her hand up right at the beginning, I might just ask you to unmute, Diane, but we've still got a few questions from the chat, so we'll get back to them. You may not need, so you don't, oops. Do you still need a question, Diane? Yes. So I've asked you. Yes. So now you should be able to speak.
Sorry, I was clicking and nothing was happening. I still couldn't speak. I've been in the situation of being hospitalised without an advanced care directive. Pardon my tears. I was trapped in hospital for a year. I had good friends who tried to find me, and when they found me, the nursing staff and the medical staff would not let them speak to me. Now I have an enduring, I can't remember all the right words, but I have the paperwork to be able to do that. And the only concern I have is my sister is a born-again Christian. So some of it she's not happy with. But in the event that, I know everything that Colleen said in the slides, but in the event that a doctor chooses to disagree with the patient and they took away my competency because I disagreed with the doctor, and I had to go through assessments, and the psychologists all said, she's more than capable of making her own decisions. Okay, she has a disability, she might need a bit of help getting from A to B, but once she's worked through with someone, she can make that choice, no problem. So I know what you said, but that was not my experience. So in the event that I was the person battling for somebody else, a friend of mine in hospital, and they don't have the paperwork, what are your options if the medical profession are stonewalling you?
I'd be going to the tribunal. We get families who are if you're advocating on behalf of someone, that's what the tribunal's there for. They're there to, and they will want to hear your opinion, and they'll make a legal determination. The doctors, we don't make that. We just say, yes, you seem to understand what was going on, but that's a legal decision. So a doctor can't actually make that. That in terms of we talk at capacity and the legal talk about competency. However, so if someone else can go to a tribunal, say this person's really not being heard, they're being stonewalled. I mean, it's a pretty serious event. Yeah, or making a complaint. Yeah.
And Diane,
and the tribunal might then have that hearing and say, no, Diane is actually quite able to make her own decisions, I think, and what she does and doesn't want, that's up to her. Yeah.
Diane, you said you had a friend or someone who could also, is that correct? You have a friend who could speak up for you if
Yes, she found me when the ambulance had taken me to hospital because I have disability. Support worker arrived and I was passed out. So they put me in hospital, and my NDIS support coordinator took on the role of next of kin.
Right.
And even when my mum found me, she rang the hospitals to find me. They wouldn't speak to her because she wasn't designated as next of kin, even though she was, and she did, the paperwork was in place for her, but I had no way to communicate that.
Diane,
So,
what I should say to you, this is that whoever you appoint needs to have copies of your documents as well, so that they can bring them. But as well as that, if you can get someone to say to the doctor, I'm going straight to the guardianship tribunal to report the way you're treating her, that can help too.
Right.
Okay. The other thing that we've done is my GP, I have a letter that never leaves my bag, that in the event I end up admitted to emergency again, it says this patient is not mentally ill, she's disabled, and this is, you know, this is her medication and it's everything. So in the event I'm in an accident or whatever, then that will be there, and they'll find that when they're looking for my ID. So that's also another thing I wanted to suggest for people.
Thank you.
I'm sorry, I can't see to use the chat.
No, that's fine. Thank you for your personal story. And I'll just put, thank you for muting again. Look, we're getting really close to the cut. I know some people were expecting only an hour, so feel free if you need to leave to just leave the meeting, and we will be posting a recording of the whole webinar. So there was just one last question that I think, it'd be good to get an answer on. Can someone who has been diagnosed with Alzheimer's make an advanced care directive? I imagine that depends on how advanced it is, but Colleen or Anne, would you like to answer that?
Yeah, that's what I was said in the in one of my slides is if you've been diagnosed with Alzheimer's is one form of dementia. So I use the umbrella term if they've been diagnosed with dementia. And because there are several forms of dementia, it depends on the level. And if you've just had a recent diagnosis, that's a really good time for you to go and get your advanced care planning done. Get your advanced directive done, appoint your enduring guardian while you still have capacity. Because often people who've just been diagnosed, dementia can last 10 years or more. And for the first couple of years, you might still have capacity. You might forget some things. Well, age does that. I used to love telling the medical students that from age 40 onwards, the speed at which information crosses your synapses starts to slow down. The mature age students didn't love me at all. And it does. I'll struggle for a word from time to time, and I turn 80 this year, folks, and, powering on. So you just... if someone has been diagnosed with dementia, yes, they can still make their own decisions up to the point where they've been diagnosed as no longer having capacity. And Anne, you might want to add to that.
The only thing I'd add is I get referrals from dementia nurses and from people who've been seen by the geriatricians in cognitive disorders clinic because they feel this is important, and while we can, let's see to what extent this person wants to capture their wishes. And then depending how far they want to go. And sometimes they are too impaired to document a whole directive. So we'll just talk through a plan and it'll be consensus, but we'll call it a plan and we'll save it for what it is. Yep.
And someone else has asked, how do people without medical training make sure they're using the correct terms in an advanced care directive and covering all possible medical situations?
Well, if you're using a well-designed advanced directive, you don't need to know the terms. You might need to understand what they mean. And as I said, the one I designed had them all defined at the beginning of the document. Most well-designed advanced directives should be written in a grade 9 language level. Any document for public distribution should be written at a grade 9 language level, no higher than a grade 9 language level. So you shouldn't need to really, you don't need a PhD to write an advanced directive.
So it might have breathing machine instead of ventilator and things. Yep.
Yeah.
And Rel asked, who should assist you to write these documents?
Well, if you
Someone you
need
trust.
assistance, I would say look at the document first, talk to family, work your way through what you think you want. My thing, Anne, would be go to your GP and discuss it. But as you said before, some people, I have the most wonderful GP. He bulk bills everybody.
Oh.
Heaven knows how long that's going to continue. But
doesn't happen here.
Well, move to the Gold Coast, Anne.
This question, I think, Penny, did you want to?
I just wanted to, there's been a couple of about accessing documents. Now, Dying with Dignity, you've had an advanced care planning guide. A number of people downloaded it before Christmas. We circulate the webinar, which we'll do. It takes a while to format and package up, but we'll email it to everyone who RSVP, so you can do all of this again. But we can do a quick revamp of our advanced planning guide, which will include Colleen's very extensive and lengthy template for an advanced care directive, but also the New South Health version, which is shorter and more values-based. And we suggest you use another form, but we suggest look at both of those as even if it's just a decision guide, it starts you thinking about circumstances you might not have contemplated. And a lot of people don't feel confident talking about medical issues, and they also can't envisage the circumstances that might be relevant to them. So we'll circulate that, we'll send around the webinar.
Thanks, Penny. Unfortunately, Penny has a terrible echo. I think sometimes her internet connection is not good, but the information she just provided was very important. So sorry about the echo. So I think we will wrap it up there, everyone. So the last slide that I had, and we will be sending the link to the recording, and I think someone mentioned Advanced Care Planning Australia has some really good quality fact sheets. So does New South Wales Health, and obviously the blank forms. It's National Advanced Care Planning Week on the 20th to the 26th of March. I've been in contact with them. They were very excited that we had a webinar happening, even when I only had 200 RSVPs. They were very impressed. So thank you everyone for taking an interest in this really important topic. And I'm sure that I will send an email around with that information about National Advanced Care Planning Week. I'm sure there'll be a lot of other webinars. There may even be face-to-face events now that COVID restrictions have eased. I think I'd like to, on behalf of all of you and Dying with Dignity, thank Colleen and Anne so much for, it was so fabulous to have two people with so much knowledge and experience. And I hope that we've answered as many of your questions as we could. And obviously, if you have further questions, you can email me, Shane, SHAYNE, at DWDNSW.org.au. And I'm sure as long as we're not flooded, if I don't know the answer myself after listening to this webinar, I might check in with Anne and Colleen. Thank you, everybody. And I'll stop so that you can all wave. And we'll
Thanks,
say
everyone.
Thank
Thanks
you.
again.
Bye.
Bye.
I always enjoy watching everyone sign off because you see all those hundreds of faces. Okay. Well, I think I'll end the meeting. So it's taking a little while for everyone to sign out. If most people have my contact details, if you do need anything important, and look forward to seeing you at the next Dying with Dignity webinar. Bye.